Hello everyone and welcome to my overview of heart failure. So this video will focus on heart failure and will be a practical overview of how heart failure presents and is managed. Most of what you know about heart failure you have learned in class, but from this video we'll talk about real life applications, real life treatment, and how you'll approach heart failure to the patient in the ward, or maybe to the exam when you get a case study. So let's begin. So by definition, heart failure is the inability of the heart to pump blood effectively to meet the body's metabolic demands. These include supply of oxygen, nutrients, and taking away of waste products. So it usually is a consequence of prior cardiovascular or respiratory events, the most common one being hypertension. We have myocardial infarctions, valvular heart diseases. We also have respiratory diseases such as chronic obstructive pulmonary disease that cause heart failure, like COPD causes right-sided heart failure. It usually is the end stage of chronic heart disease. It is important for us to know about this because it is part of the management of heart failure. If you're having a patient with myocardial infarction and heart failure, you will need to keep this patient maybe on a certain type of medication, like if the myocardial infarction was caused by a stroke or maybe a clot going into the heart, you need to put this patient on thrombolytic medication. Same for COPD, you need to put this patient on appropriate medication to manage the COPD to reduce the effects of heart disease. The body receives blood from the rest of the body, the right side of the heart, sorry. Uh, that means if we have congestion in the right ventricle, blood will go back into the inferior vena cava and superior vena cava, and it will give us the characteristic symptoms of right-sided heart failure, including jugular venous distension. If we have liver involvement or maybe damage to the liver also, we'll have the congestion of the veins on the abdomen presenting as caput medusa. In fact, cardiac failure can lead to liver failure by what we call cardiac hepatitis. So it's primarily caused by chronic obstructive pulmonary disease because this is one of the diseases that damages the lungs, increases the resistance, causing blood to go back into the right ventricle more. And another condition in children is tetralogy of Fallot, which I know you know very well. In many cases, this heart failure caused, right-sided heart failure caused by chronic obstructive pulmonary disease will be called copulmonale. It can also be caused by pulmonary emboli inside the lungs, interrupting blood supply to the lungs, blood backs up, less oxygenation, the symptoms of right-sided heart failure. Obstructive sleep apnea. In fact, this is a new way of people looking at heart failure in obese people. It's been suggested that when you are heavyset or you are obese, when you sleep, there is compression of the trachea, there is less oxygenation, resistance builds up in the lung, blood supply now is being interrupted, less oxygenation, the heart on the right side pumps even harder to try and meet these demands of less oxygen supply to the rest of the body because of compression of the trachea. The end result is right-sided heart failure. Then we have what we call the New York Heart Association classification. And this is a simpler way of classifying. We have 1, 2, 3, and 4. This depends on the symptoms, and it's one of the ways you'll be needing to very fast classify your heart failure, either in the wards, in your class, or when you are with the patient. So for type 1, we have structural myocardial changes. These you'll need to see in an X-ray, and you will have left ventricular hypertrophy, and we'll also have maybe things like apex deviation. The apex moves more laterally, And with this movement, you'll only need to hear it via a stethoscope or palpation of the apex beat, the point of maximal impulse. So one other way of trying to see these myocardial changes is through the help of an ultrasound, a specific ultrasound, a cardiac ultrasound that we call an echo. It's kind of a live ultrasound. Then we also have type 2, where we have small decrease in exercise tolerance. Let's say, for example, your patient will say they were able to go from their bed to the shop when they wake up, but now they get tired halfway to the shop. That small decrease in exercise tolerance. Then you have significant decrease in exercise tolerance. They'll say, I was climbing up to 10 staircases or 10 stairs, but now I can only do around 2 or 3, and I have severe shortness of breath, maybe with chest pain and intolerability totally. Then we have type 4, where we have symptoms of heart failure in rest or during small exercise. Remember when I told you in right-sided heart failure, when a person is lying flat, they end up experiencing shortness of breath. This is one of it in type 4. We are now completing the cycle of heart failure. This person will have a completely damaged heart that will have poor functionality. So let's look at the pathophysiology. So for the pathophysiology, these are the mechanisms, what you're seeing on the screen, the mechanisms of how heart failure arises. One of the mechanisms is pump failure. This is usually from ischemic heart diseases and thrombotic events, such as coronary artery diseases. We have deposition of amyloids and also myocarditis. Pump failure. The muscles are not contracting well. When we have ischemic heart disease, a certain part of the heart dies or is temporarily set inactive that it cannot contract the whole of the ventricle well. So with poor contraction of the ventricle, we'll have a mural thrombi. Later on, a thrombus will form because of the stasis event of the blood. Myocarditis from infections, and one of the infections that we know is from retroviral diseases. We also have flow obstruction in valve stenosis. If we have stenosis of the valves, then we'll have poor flowing of the blood forward. An example is in rheumatic heart disease. Mitral stenosis is a very, very common feature in rheumatic heart disease. Then we have valve regurgitation. This is the failure of the valves to close well. So blood goes back into the lung, into the ventricles or the atria from where it was flowing into, and then we'll have dilation of that part that the blood is going back into. We also have shunted flow. This is common in children. Ventriculoseptal defects, where we have an opening from one side of the heart into another. This causes pressure volume overload on the right ventricle, causing right-sided heart failure. Remember we talked about tetralogy of Fallot. Tetralogy of Fallot contains several manifestations, right? Ventricular hypertrophy, overriding aorta. We have right-sided heart failure. The ventricles thicken, right? Ventricular hypertrophy that we have just talked about. We have around 4 or 5 manifestations of it that cause this shunted flow in ventricular septal defects, common in tetralogy of Fallot. Then we have disorders of cardiac conduction. The heart never stops, and it gets this feature from its ability to generate its own electricity. We have the sinoatrial nodes that have specialized in creation of this action potential. So let's say, for example, you have a condition like what? Let's give an example of rheumatic heart fever. In rheumatic heart fever, there is damage to the mitral valves, and with this damage to the mitral valves, we have vegetative growths on the valves, and these vegetations press on the anteroventricular node. The mitral valve is near the AV node. With compression of the AV node, we have poor flow of the action potential. We have what we call bundle branch blocks, because the atrioventricular node then allows for the electrical current to go into the left branch and the right branch. If we have the compression of this AV node, it means that we'll have poor flow of the current, and with poor flow of the current, we have the bundle branch blocks, and then the sinoatrial node will try to compensate. This will end up causing it to beat even faster. We also have other causes, like just diseases of the conduction system, the sinoatrial node. Maybe someone had a myocardial infarction. There is poor blood supply to the sinoatrial node, because we have the blood vessels that supply the sinoatrial node. With poor blood supply to the sinoatrial nodes, the end result is that we'll have these fibrillations, atrial fibrillations, and the ventricular fibrillations. We have rupture of the heart or major vessels, such as in aortic dissection. These are kind of rare diseases: aortic dissection and myocardial rupture. So the body has to get blood and oxygen. Now the heart will be told it has to maintain blood supply. So we are going to look at the mechanisms in which the heart is able to achieve this. Despite it failing, it still needs to provide blood. So cardiac output can be increased by volume, and this occurs during diastole. Diastole is the filling of the ventricles. When we increase the volume of blood during diastole, it means that we will have more blood supply to the rest of the body. This increase in volume, remember we talked about cardiac output being stroke volume times the heart rate. When you increase the volume, increase the cardiac output. We can also cause hypertrophy. Hypertrophy is enlargement of the cells of the heart. The cardiomyocytes become enlarged. This will become a problem that we're going to see, because with enlargement, we'll need to fill the spaces and we'll have poor blood supply. Then we have other neurohormonal mechanisms. Especially the atria are enlarged, their walls become thin, and with this enlargement, the heart senses. It has sensors on the atria. These sensors then trigger the release of ANP, atrial natriuretic peptide. It's a hormone produced by the heart. This ANP goes and tells the kidneys that there is dilation of the heart, so we need to reduce the volume. So this person tries to balance their body internally by reducing the blood volume and maybe the heart rate. So this is why you end up seeing like a person can come with heart failure but with low blood pressures. It's because of this mechanism. Then we have the renin-angiotensin-aldosterone system. This does the opposite. It increases the stroke volume or the heart rate. The renin produced by the kidneys affecting the angiotensin, the aldosterone. Aldosterone is a vasoconstrictor, allows for increased systemic resistance, and most of the time where the resistance happens is the renal arterioles. These arterioles, we have the afferent and the efferent arterioles. They help increase systemic pressures to cause the heart to increase the cardiac output. This is what causes hypertension in a person with heart failure. You might find a person with low blood pressures, maybe the ANP is active, or with hypertension, the RAS is active, or a person with left-sided heart failure, not supposed to be having edema, now they have edema. What's happening? That is the renin-angiotensin-aldosterone system being activated. We have the central nervous system, the vagus nerve being activated. The vagus nerve, it supplies the covering of the heart. It branches and forms part of the phrenic nerve that supplies the sac that holds the heart. This sac then, or these branches of this nervous system tell the heart to beat faster. Remember, stroke volume times heart rate. You increase the heart rate, you increase the cardiac output. The vagus nerve increases the heart rate, it causes the heart to beat faster. This is one way of why you will see a patient with heart failure end with tachycardia. It's also the mechanism by which most neuroendocrine hormones work. These are epinephrine and norepinephrine. They increase heart rate via these nerves. And we also have things like thyroid hormones causing activation of these stress hormones, and also the nerves increasing the heart. So these nerves usually are able to sense increased or decreased cardiac output. We have talked about atrial natriuretic peptide causing increased vasodilation and diuresis, reducing blood in the body, lowering blood pressures. We said this is the mechanism by which you see a patient with low blood pressures. It is the atrial natriuretic peptide working. For the RAS system, we'll have increased BPs. Maybe the low blood pressures are causing, or the low cardiac output triggers the activation of the renin-angiotensin-aldosterone system, causing an increase in heart rate. And an increase in heart rate, what then happens? Of course, we'll have increased cardiac output. The heart beats faster. With it beating faster, it delivers more blood and more oxygen. But this works out indifferent to what the heart expects, and it ends up failing. We'll end up having things like fibrillations that we talked about. So it's important to know Frank-Starling mechanism as a way of the body compensating. You can see the curve for heart failure. The stroke volume is lower, despite us having the same left ventricular and diastolic pressures. So let's talk about cardiac hypertrophy. So we said in a person maybe with heart failure, you might find hypertrophy as a symptom. We have dilation and hypertrophy. In a person with increased systemic vascular resistance, remember we said resistance is common, and many of the times it will happen at the renal arterioles. With increased resistance, maybe these arterioles have become deposited with more plaque. Maybe this person is obese, there's a lot of plaque inside these renal arterioles, or maybe there's just damage to these renal arterioles. What happens next is that this heart has to compensate. We are not getting enough blood to the rest of the body. How does it compensate? Increase the musculature. When you increase the musculature, the heart has now more ability to pump blood even much more strong. You can see the picture on the right. We have the thickened ventricular septum, and this hypertrophy works out indifferent to what the heart expects. In the end, we'll have reduced space for blood to fill. Like you can see, there is a smaller volume of the left ventricle, so we'll have lesser blood being delivered. It's a compensatory mechanism. It's a cardiac remodeling mechanism that works out wrongly for them. Like, just look at this heart. Look how the ventricles are huge. Blood takes a longer time, and it has to struggle to get from the edge into the heart, the deepest part of the muscle. So usually in hypertrophy, these farthest parts don't get enough blood, and this ends up causing death of these parts. Then we'll have things like heart failure later on. We'll also have poor conduction because the walls are so thick. Electricity does not pass into these areas easily, and that is why in cardiac hypertrophy, maybe let's say ventricular hypertrophy, you will see things like delayed conduction. You will have prolonged or spread out QRS complexes. The QRS waves will take longer times than normal. It's because we have a problem depolarizing these ventricles. Remember, QRS is ventricular depolarization. Then we'll have low capillary density. We have talked about it. A low blood supply because the vessels are not able to reach deeper into the muscles and further, causing hypoxias that cause arrhythmias, myocardial infarctions, lead to thrombosis and failure, causing apoptosis of programmed cell death. This is a histological slide of heart failure. You can see on the left, the spaces are so thin, and the nuclei are small. Remember we talked about increased protein synthesis, increased size of the nuclei, increased mitochondria, more sarcomeres. On the right we see more sarcomeres. The cells are huge. The reddish pinkish cells are huge. The nuclei are huge. And you will see that there are more white parts. The white parts are amyloids. These are depositions. These are proteins. The amyloids will work out of favor because these are scars, like scars. And you know, with scars we have poor blood supply. They don't get enough blood supply. With these scars we'll have poor conduction, and also this space filled by scars will end up dying later on, causing the problems that we've talked about, infections and so on. What are the causes of heart failure? We have talked about the mechanism. These are mechanisms that then cause heart failure. The most common causes are the valvular diseases, e.g. mitral stenosis. We have talked about in rheumatic heart fever, compressing the atrioventricular node, causing fibrillation. The stenosis also prevents blood from going forward. With prevention of that, we'll have backing up of blood, we'll have cardiac dilatation. The dilatation, we have congestion in the lungs, the rest of the body, pulmonary edemas, and generalized edemas too, anasarcas. Then we have hypertension, causing pressure overload. That causes left ventricular hypertrophy we have talked about. In fact, the most common cause of left ventricular hypertrophy is hypertension. It increases systemic vascular resistance in the arterioles. Then we have myocardial infarction, death of part of the heart. Because of this part dying, like in the lower picture you seeing the dark part, that part of the heart is dead or is dying. So that part will not contract because it's not responding to signals like the other cardiomyocytes. The end result, that side fails. So all this combined or singularly will cause the heart to try and increase the cardiac output, will have increased work on the heart, and then we'll have increased wall stress and will cause the hypertrophy we've talked about. Hypertrophy causes the heart to be heavier, thicker, the protein synthesis, the fetal gene programs, the fibrosis, we talked about the myeloids depositing in the extracellular matrix, causing the heart to be bigger, poor supplied with blood, and eventually death. Then we have these causing heart failure, causing both systolic. Systolic is contraction of the heart. Diastolic is filling of the heart. In fact, we have what we call systolic and diastolic heart failure. In systolic heart failure, we have inability of the heart to pump blood. Diastolic, poor filling of the ventricles, so we have poor supply. We also have another type of heart failure classification that we did not talk about, we'll talk about later. Heart failure with reduced or preserved ejection fraction. What are the risk factors for heart failure? Hypertension, obesity, previous history of heart diseases. We have talked about coronary artery diseases, myocardial infarctions, valvular heart diseases, infectious diseases that cause valvular diseases like rheumatoid heart fevers. And then we have diabetes. Diabetes is very complicated. Not only does it cause atherosclerosis, but diabetes damages the nerves. And with damage to the nerve, these people will not feel a heart attack coming. This heart attack will take a long time, happening over time, and this patient will come with damaged part of the heart that they did not feel the common the common myocardial infarction symptoms, the heart attack symptoms of left jaw pain, pain radiating to the left arm. They will not feel that, the left-sided pain, chest pain. They will not feel that. It will happen silently and it will kill them, or it will bring them already in heart failure. Obesity, we talked about it, compression of the trachea, poor oxygen supply, increased pulmonary resistance, heart failure. Smoking, we know about atherosclerosis and smoking. We know about cancer and smoking. We have a familial history of cardiovascular diseases. If your parents had hypertension, had heart failure, you will most likely get it later on in life. We have chronic kidney diseases, liver diseases such as cirrhosis. We talked about cardiac cirrhosis. We have excessive alcohol consumption. This is a very pertinent topic of discussion. How does alcohol cause heart failure? Alcohol is a toxin to the heart. It damages the heart directly, but also affects the vasculature. It increases resistance of the blood vessels. That's how alcohol works. And with increased resistance, systemic resistance or damage to the myocardiocytes of the heart, I've talked, that term did not fit in well. Myocardiocytes of the heart is supposed to be the myocardiocytes. Then we'll end up having heart failure. Then we have valvular heart diseases such as stenosis, rheumatic heart fever. We have regurgitation too. The signs and symptoms, we talked about the classification left and right. So remember, in left-sided heart failure, we have poor end organ perfusion. So we'll end up having these symptoms coming in earlier. And these people are going to be acutely dyspneic. They are going to have shortness of breath and there will be a cough because of blood going back to the lungs. In right-sided heart failure, we talked about generalized congestion, so they'll come with edema, jugular venous distension, maybe with hepatomegaly if it's advanced. They'll have fatigue, orthopnea, paroxysmal nocturnal dyspnea, jugular venous distension, edema, peripheral edema occurs in right-sided heart failure, reduced exercise intolerance. This is because we said in definition of heart failure, inability of the heart to meet the body's metabolic demands. When exercising or walking or talking or doing anything, the body needs oxygen, and with the heart failing, then we'll have reduced tolerance because the body needs to preserve the little oxygen that it has for the basic functions, basic essential functions such as breathing, the brain, and so on. In children, we have reduced playfulness, we have cyanosis, squatting, and failure to thrive. This squatting comes in tetralogy of Fallot. When these children, you will see these children go on their feet and go down and squat. This is because when they squat, we have reduced resistance to the rest of the body, and with the reduced resistance, blood is able to flow well. Because in tetralogy of Fallot, we have the ventricular septal defects, blood mixes through the ventricles, and with this increased resistance now, blood reduces its mixing in the ventricles, it goes to the rest of the body, more oxygen is delivered, and they feel better. So these children will prefer to squat. This is what we'll talk about in pediatrics a little bit later on. So early recognition of these symptoms is very important to increase or to improve the prognosis, make the prognosis positive. This is a child with central and peripheral cyanosis. You can see the finger clubbing, the shiny parts of the fingers, also with the bluish discoloration of the nails, the tongue appearing blue. This is because you have poor oxygen supply. Remember in tetralogy of Fallot, ventricular septal defect, right ventricular hypertrophy, overriding aorta. What else? You usually have the mnemonic PROV. Yeah, this the other one kind of forgotten. This is jugular distension. Then we have systolic and diastolic heart failure. We talked about systole being contraction and emptying of the ventricles. Diastole is the filling of blood inside the ventricles. So we have some terminologies we need to know before we continue. We have end diastolic volume. This is the amount of blood in the ventricles after filling up during diastole. Remember, diastole is the filling up of the ventricles with blood. And with blood filling inside the ventricles, it has to have an endpoint. The point at which now the blood is completely filled inside of these ventricles is called end diastolic volume. Remember, in a person with hypertrophy, because the ventricle is narrowed, is smaller, we'll have a shorter end diastolic or a smaller end diastolic volume. And if a person has a dilated heart, cardiac dilated wall of the heart, that means it will expand even more And with more expansion, poor signaling, it's one of the most common cause of fibrillations. This will cause an increased end diastolic volume. And then we have the end systolic volume. This speaks for itself. Systole, contraction of the heart. With the amount of blood in these ventricles, we count the amount that is left in the ventricles after the contraction as end systolic volume. And one thing to note is that during contraction of the heart, not all blood is pumped out. Just a fraction of it is pumped out. So the fraction that is pumped out is called the ejection fraction. And this is usually around 50 to 75% of the volume that is inside the ventricle. The fraction that is pumped out is called the ejection fraction. And this is usually 50 to 75. If a person has 45 to 50%, this is borderline reduced ejection fraction. And if only 40% of the volume inside the ventricle is pumped out or less, then we have inadequate ejection fraction. This is what we call reduced ejection fraction. Heart failure with reduced ejection fraction. If we have heart failure, but the amount being pumped forward is the same, that means we have a preserved ejection fraction. That is called heart failure with preserved ejection fraction. Let me repeat. The ejection fraction is the amount of blood that is pumped from the ventricle. Not all blood is pumped forward. Only around 50 to 75% of blood inside the ventricle is pumped forward. So around 50 to 25% remains. And this amount that remains is important to us. Why? Because in a patient who has maybe a disease affecting filling of the heart, maybe in hypertrophy, we have reduced ejection or an increased ejection fraction in a certain instance, the percentage that is pumped will be lesser and lesser as we continue in heart failure. I talked about it being borderline or inadequate, also called reduced ejection fraction. This is what we just talked about. So one of the causes of heart failure with reduced ejection fraction is ischemic heart disease. Remember, in ischemic heart disease, a part of the heart does not get enough blood supply, and with the coronary arteries not supplying blood well to this part, maybe because of atherosclerosis, thrombosis, or any other event that causes this, that means it will not be able to squeeze well. So the volume that is pushed forward is less. This is systolic heart failure, failure in pumping. We also have dilated cardiomyopathy. The walls of the heart becomes thin and the ventricles become filled with blood, or the artery become filled with blood. Because of this dilatation, what happens is that there is not enough musculature to push the blood forward. So we'll have reduced ejection fraction. We'll also have mitral insufficiency. The valves are not able to work properly. And what do we mean by insufficiency? They do not close properly. When you do not close properly, blood goes back. So the fraction of blood that is pushed to the next step is less because a part of it comes back. Then in heart failure with preserved ejection fraction, we've talked about this being a diastolic kind of heart failure. And one of the causes is interstitial fibrosis. Maybe we have cardiac hypertrophy. The muscles have become thick and the ventricles are smaller. The size, the volume is reduced. Now, yes, we are pumping the exact amount because the ventricles, remember, the ventricles became thick to supply the body, to meet the body's metabolic demands, to increase the cardiac output, stroke volume times the heart rate, to increase the stroke volume. And because of this hypertrophy that has occurred, we have fibrosis. Yes, the blood will be of the same amount, but we have heart failure. The ejection fraction is preserved. Causes include older age, hypertension, aortic stenosis. Aortic stenosis we will see a lot in older people. We have diabetes and the amyloid depositions and fibrosis we talked about, cardiac hypertrophy. How do we diagnose heart failure? One of the most cheapest, or for me on my place where I've worked or I still work, diagnostic tool is a chest x-ray. It's very cheap, it's very fast, it's detailed to confirm for you the diagnosis as you need. It helps in diagnosis of cardiomegaly, this increased size of the heart. The heart should be 50% the diameter of the chest. Anything above 50% is cardiomegaly. And then we have pulmonary edema. You will see those streaking signs, the nodules, the signs of pulmonary edema, the batwing signs. It's called the batwing signs. You will see a silhouette like a bat, a white colored silhouette on the heart, both sides creating like a bat wing size on the x-ray. We have pleural effusions. These effusions, remember, transudate or exudate? It's up to you to find out. Signs of hepatomegaly. Remember, cardiac hepatitis. We have echocardiograms, echoes. It will show you valvular heart diseases. It will show you septal and muscular defects of the heart, such as ventricular septal defects, ASD, and so on. It will also help you in quantifying the end systolic volume and end diastolic volume. In fact, we diagnose heart failure with preserved or reduced ejection fraction using an echocardiogram. We have a chest, CT of the chest, a CT angiogram. Remember we talked about pulmonary embolism being a cause of heart failure. We have cardiomegaly that can be detected on a CT chest, maybe not with an angiogram. When you go with the CT angiogram, you're thinking about a thrombus or an occlusive event. They will also help you in diagnosis of congenital defects, such as in Marfan syndrome. In Marfan syndrome, we can have coarctation of the aorta. We may have in syphilis, in advanced syphilis, we have aortitis. Then we have electrocardiograms. Very important. Any person with heart failure should be done for an X-ray, an echocardiogram, maybe not a CT angiogram or a CT chest unless really needed. I reduce the exposure to radiation. So you need to do an X-ray at least, an echocardiogram, or you can go to an echocardiogram without the necessary need for an X-ray unless you're looking for edemas, the effusions, or any other signs. And then you'll also need an electrocardiogram. Remember we said when the heart is dilated, we'll have fibrillation. So when you have rheumatic heart disease, compression of the atrioventricular node causes bundle branch blocks. So it's very important for us to do an electrocardiogram. And this is also important in people with diabetes. Any patient with diabetes and hypertension, or with diabetes and you suspect heart involvement or cardiovascular involvement, very important for you to do an electrocardiogram. Why? We said that diabetes damages the nerves, so they do not feel a heart attack occurring most of the time. So it will go unnoticed. The fibrillations, the heart damages will go unnoticed. It's up to you to find this out. You can do cardiac biomarkers in a person with suspected myocardial infarctions. Do the troponin ICE, and usually please wait for at least 2 hours. As we know, in my workplace we say at least hold on for 2 hours for you to get accurate sealing for these troponins. We have the creatine kinases, also important. I don't know if they are still in use, but I haven't seen much of it lately. We have lipid panels. Remember, myocardial infarctions can be caused not only by thrombosis, but also by atherosclerosis or fatty depositions that break off. Remember the low density lipoproteins. These lipoproteins are low density. They are not able to float. Oh, no, not really. Yeah. What does low density lipoprotein mean? Let me get my bearings. Yeah, so I've gotten it. If we have high density, it means they're able to sink in blood and be carried forward. If they're low density lipoproteins, it means they float. And when they float, when blood hits the vessels while passing through, These stick onto the vessels, they accumulate, they end up closing or blocking these vessels, especially in the coronary vessels, causing myocardial infarctions. In the brain, we can have things like strokes. And this is why it's also important to give antifibrinolytics or these fibrinolytics in people who have had myocardial infarction or are at risk to try and lower these lipids. Atorvastatin is a very good agent. Hypercholesteremia is very good to diagnose in people with heart failure. It's very important via lipid panel. This also causes myocardial infarction. You can do a liver panel if you need to, because of maybe albumins and whatnot with edema that you have with the patient. You need a full hemogram. Remember, in heart failure, we end up having problems like iron deficiency anemia. Hepcidin is involved. So diagnose this iron deficiency anemia, correct it. You will see anemia common in people with heart failure. You need to correct at least if your protocol allows, or depending on the presentation of the patient. In full hemogram, will also detect infectious causes of heart failure, myocarditis, valvular heart diseases, rheumatic heart fever. How do you diagnose it? Laboratory tests are part of it. Remember, it's a bacterial infection. Molecular mimicry, we have the bacteria, we have the M protein molecular mimicry on the valves. What happens next? It's a bacterial infection. The leukocytes will be up. Check for leukocytes in full hemogram. Check for the platelet problem. Do a coagulation profile, hypercoagulability. Remember the vitreous triad. Do an assort for RHD. You can do cardiac ultrasound. We have non-pharmacological management and prevention of heart failure. You need to do aggressive lifestyle modifications, especially in the early stages of heart failure, to try and prevent advance into severe disease. You need to tell them to watch their diet. Low cholesterol food, low sugar reduces comorbidity with diabetes. Low sodium foods. And also, because of the effect of heart failure on the kidneys, we need to reduce at least the potassium intake, not only the sodium. So if we have electrolyte abnormalities, especially with hyper or hyperkalemia, especially, is the most common manifestation. You can advise them to avoid low-hanging fruits, avocados, bananas, rich in potassium. Then we have regular exercises, especially aerobic exercises, for at least 30 minutes a day, several times a week. Then we have smoking cessation in people with smoking issues or drinking issues. Remember, we said alcohol is a direct toxin to the heart. You need to tell them to watch their weight. Their waist ratio needs to be within limit. Their BMI 18.5 to 24.9. Above that, we are increasing heart failure issues, not only with obstructive sleep apnea, but also predisposing them to diabetes. And the heart has to work even harder to compensate for this obesity. So, weight management is very key. So, let's start. For the angiotensin converting enzyme inhibitors, these are center stage in management of heart failure. They help in preventing heart failure with reduced ejection fraction and reduce hospitalization and mortality rates caused by heart failure. They help in prevention of conversion of angiotensin 1 into angiotensin 2, which works as a vasoconstrictor, but also remember when angiotensin 2 causes production of aldosterone, which is also another vasoconstrictor and causes sodium retention. And with reduced sodium retention and vasoconstriction, you help reduce volume overload and systemic vascular resistance common in heart failure. So this is one of the agents that will be very, very much used in heart failure, and an example is enalapril. You'll find some people preferring angiotensin receptor blockers over enalapril. It depends on the preference. They'll target the same thing, action of angiotensin 2. They both prevent or reduce action of angiotensin 2 either by preventing its overproduction or preventing the action of angiotensin 2 directly by blocking the receptors. Remember, the renin-angiotensin-aldosterone system, I said it's usually activated when we have heart failure, because especially left-sided heart failure, because we have poor perfusion of the end organs. And one of the most common type of heart failure is usually left-sided heart failure. Then we have talked about the angiotensin receptor blockers. We're blocking the receptors. Here we have agents like losartan and telmisartan. For the ACIs, we have enalapril, captopril, and lisinopril. These usually start at 5 milligrams a tablet, going upwards 10. And then we have the ARBs. Losartan can start with 50 milligrams, going to 100. Then we have the beta blockers, examples like carvedilol, propranolol, atenolol, metoprolol, and bisoprolol. We have selective and non-selective ones. So depending on what you need, choose effectively. They help reduce rate. They balance the fibrillations that might occur in heart failure that we talked about in cardiac dilated cardiomyopathies and maybe hypertrophies and myocardial infections that end up causing them. So they help in reduce in managing the contractility of the heart. They also manage blood pressure. You'll see them very common in blood pressure, but most in people with myocardial infarction or histories or risk of myocardial infarctions or with fibrillation. Then we have the mineralocorticoid receptor antagonists, the MRAs like aldactone. These prevent sodium retention and reduce cardiac remodeling. Remember, wherever sodium goes, water follows. Sodium goes, water follows. When you reduce reabsorption of sodium, you essentially reduce reabsorption of water and retention of water. Examples include spironolactone and eplerenone. They help improve the symptoms and also target heart failure with reduced ejection fraction. Then the new agents, the anise-angiotensin receptor neprilysin inhibitors like sacubitril and valsartan, they increase these beneficial peptides. Remember, we said in heart failure there will be increased production of arterial natriuretic peptide, especially in dilated cardiomyopathy, in response to increased volume of the ventricles and the atrium, especially the atria. They are produced in dilation of the atria. These ANPs help reduce the volume. They tell the kidneys that we need to go slow. Now the heart is struggling, and we'll need to agonize them more to help the heart. So they help in heart failure, reduce ejection fraction, reduce mortalities and hospitalization. They are being used in some places in place of the ACIs and ARBs. Remember, when you're using angiotensin converting enzyme inhibitors, you are inhibiting the breakdown of bradykinins, and the bradykinins cause cough. So in people using ACIs, if you hear a cough, they're complaining of cough, is because you have buildup of bradykinins. You should consider switching from an ACI to an ARB. Then we have the all too common diuretics, including furosemide, hydrochlorothiazide, and chlorthalidone. So they increase urine output and decrease fluid retention. These are very dependent on proteins. So ensure that, especially Lasix, furosemide, ensure that your patient has enough proteins. Check your proteins. You might be pumping Lasix or furosemide, but it's not being bounded, transported well because of low proteins. They'll help you very much in treating these patients with edema. They help subside edema quickly, but monitor your blood pressures. Another thing to note is that when we talked about heart failure coming with hypotension, especially if we have activation of the ANPs or the cardiac output being affected generally, by any other factor. Then we have the sodium glucose transporter 2 inhibitors. These are very common in people with comorbid diabetes. They help reduce the reabsorption of both sodium and glucose, the use of the cotransporter 2 in the proximal convoluted tubules of the kidneys. One thing to note is that they are used in treatment of diabetes, especially type 2, but they will not help your diabetes. They just help reduce the amount of sugar in circulation. But remember, in type 2 diabetes, what do we have? Insulin resistance in the adipose and skeletal tissues. So this does not help that. It only helps with excretion. So don't directly treat diabetes with this, but add it to help you in management of diabetes. They also cause increased natriuresis. Remember, wherever sodium goes, water follows. And with that, we help reduce the cardiac overload. And this will bring about the side effects common in these drugs, the hyponatremias. So always check your sodium levels before giving them, and at least try and track the sodium levels in people with them. And with them reducing sodium and water, blood pressure goes down. Very beneficial in heart failure with reduced ejection fraction. Another thing I want to talk about is the fixed dose combinations. These are drugs that we are seeing all too common in the market. People are combining drugs, and when you combine, you reduce pill burden, enhances adherence, and improves the well-being of the patient. Remember, treatment of the patient is not only pharmacological, but we have lifestyle issues. We also have psychological issues. One of the common causes of hypertension and heart issues is psychological well-being. Remember Takotsubo cardiomyopathy, Takotsubo heart failure, broken heart syndrome, people developing heart failure from psychiatric and psychogenic issues. So it's very important you try and monitor them. And one of the ways of reducing these psychiatric and psychogenic issues, try and reduce the pill burden. We already have given these patients 4 or 5 drugs. In common management of heart failure, we usually use an enalapril. You add maybe like acavediol. You add a Lasix if they have edema. Then you might find someone adding a spironolactone or not. You might find someone adding a CCB, amlodipine or nifedipine. Those are 5 drugs. If this person unfortunately also has diabetes, maybe they're adding glibenclamide or metformin or both, glibenclamide and metformin. Those are around 7 drugs. So if you can give a pill that has 3 drugs, we have knocked off 3 drugs. You just give them 2 drugs, but they contain 4 or 5 drugs in many cases. So it's very beneficial to the patient. Try and consider this. It will improve the outcome of your patient. What are some of the incidental findings in heart failure? Iron deficiency anemia are very common. Nowadays I see it common in people with heart failure. It's being theorized because of hepcidin in circulation working for causing that. So read about iron deficiency anemia, know about it in people with heart failure and how to manage and how to at least help them. Remember also, giving too much iron, hemochromatosis, causes damage to the heart. We have renal dysfunction. Remember we talked about the arterioles, the renal arterioles being the most affected and causing the systemic vascular resistance. So renal dysfunction will eventually come in people with cardiac issues, and it can also be the cause of the cardiac issues. So with renal dysfunction, please watch out for the EGFR, the creatinines. Another thing to watch out for is the hyperkalemia, hyponatremia, the electrolyte abnormalities. We talked about the low-hanging fruits. We talked about avoiding the low-hanging fruits in people with hyperkalemia, bananas, avocados, things like that. We talked about it. Then we have obstructive sleep apnea. Remember obesity, it will be common. Cachexia, remember these people are losing proteins maybe in urine. There is damage to the kidneys also. Or the edema, remember edema causes extravasation of these proteins, and with the extravasation they cause increased thrombotic pressure, they pull water, we have edema, proteins not in circulation, drugs are not being carried, hormones are not being carried. Hormones need these binding proteins. These proteins are needed for muscle building properties all over the body. So it's important to replenish proteins when needs be, not only for your pharmacological management, but well-being of the patient. So that is the lesson for today. Thank you for watching the video.